Hello, Dr. Samaras.
Hello.
Yeah, hi.
Hello,
Welcome.
nice to meet you.
Pleasure. Thank you very much for joining.
And thank you for the invitation.
Most welcome. So our host will be joining soon.
Okay.
Dr. 𝑎𝒊𝒏𝒔𝒕𝒊𝒏. In the meanwhile, if you would like to check your PowerPoint.
Can I try to share the PowerPoint?
Please.
Okay. Also, share is.
There's a green button. Green button on the Zoom.
Yeah. Yes.
Yes. Okay.
Okay, but if I open
Can you make it full screen?
Yes. Just a second. Here.
Okay. It's working well. Are there any videos here?
No videos.
No videos. Okay, fine. Then I'll stop your PowerPoint.
Okay, as I stop the presentation and I enter later.
So our host is here. Hello, Alberto.
Hi, Raja. How are you doing?
I'm fine, thank you. Wish you a happy new year in advance, both of you.
You too, Raja. Thank you very much. Hi, Tamara. Good to see you.
Hi, Alberto. And I want to thank you for this opportunity.
No, we are thanking you for taking your time to share with us your presentation. Thank you so much.
𝑏𝒂𝒏𝒔𝒕𝒊𝒏 is here with us.
Yeah, Professor 𝑏𝒂𝒏𝒔𝒕𝒊𝒏 just connected, I see.
Hi.
Good morning, Professor
Hello, Professor.
Hi, how are you guys?
We're good.
Good, thank you.
Thank you. Wish you a happy new year, Prof.
Happy New Year to you all.
Thank you.
Thank you. And thank you for joining us at this time in the morning. It's very early over there.
It is almost 5 in the morning.
Yeah,
what
on
time
Sunday.
is in Italy?
Now it's almost noon in Italy.
Yes,
so
yes.
Much better for a webinar than 5 a.m.
It's all good.
Yeah, thank you very much. But you know, it's always very difficult to match timing
Of
all
course.
over. So we really appreciate that you could join us. Thank you so much.
You're welcome.
So Raja, we have to wait for Professor Kato, Issue, Ari, and the others, I think. Okay, Tamara, you have checked already your PowerPoint.
I've already checked the PowerPoint and the sharing.
Okay, good.
Yes. Okay, Prof. Kato is here.
Yes.
Hello, Prof.
Happy New Year.
Hello.
Happy New Year to you.
It was very nice webinar last night.
Thank you very much, Prof.
Arigato.
Prof. 𝑏𝒂𝒏𝒔𝒕𝒊𝒏 is here with us.
Hi, 𝑏𝒂𝒏𝒔𝒄𝒑. How are you?
Hi, good.
Hi.
Good
Happy New Year. How are you?
Happy New Year to you all.
Thank you very much.
You're welcome. Thank you.
So when did you come to Nagoya? Maybe how many years back?
Nagoya, I was Sugita Scholar back in 1993 to 94.
Maybe I think you can understand a little Japanese.
I used to better, now I forgot. But you know, almost every year I go back to Japan. So with family vacation or
really?
yeah.
You should visit us, please.
I would love to.
Yes, please. Anyway, thank you very much for accepting our invitation this time.
Oh, my honor, my honor.
Thanks. Amba sensei, こんばんは。
こんばんは、先生。お元気ですか？
元気。So, Tamara, maybe the
So unfortunately, I don't speak any words in Japanese, but thank you very much for this opportunity and nice to meet you.
Yes. So, 𝑘𝒂𝒂𝒂, the Tamara is coming to Japan in a few weeks after. Yes, so she's invited.
So thank you so much, and I especially want to thank obviously Alberto because created this joint opportunity.
Okay, that's a good time for you to learn Japanese.
Okay, so I see Harry also joined. Hello, Harry.
Hello, everyone.
Hello, hi.
Hello.
Hey,
Hello.
And I see Liu also.
Liu Sensei, welcome.
I see Dr. Atik.
Yeah, hello everyone. How are you?
Hi, Atik.
Hello.
Yeah.
𝑘𝒂𝒂𝒂, the Dr. Atik is from the Bangladesh.
Very
Hello,
nice.
Professor. How are you?
Hello. Good. How are you?
Yeah, there are lots of fans in Bangladesh of you.
Oh, thank you very much.
Yeah.
Timur is here. Hello, Timur Sensei.
And also, Dr. Suki, she's with us now. I think, Suki, you can speak Japanese now.
A little with Duolingo.
Huh?
We are using that app to learn little Japanese, but it's different, and what you speak is different.
No.
It's nice. It's nice.
Yeah, we also have Dr. Afzal joined us. Hello, Afzal.
Hello.
No. So Dr. 𝒂𝒂𝒂𝒂, the Afzal, originally from India, but now she studied in Germany, and now she's a fellow in India now.
Yes.
Nice.
Okay.
Hello, Sensei.
Hi.
It's Dr. Shahnaz from Bangladesh, and great to join.
Thank you very much.
Everyone.
Yes. So today is a president election of the Bangladesh. Today or tomorrow?
Yeah, Dr. Arifit will present his work on bypass of Myanmar disease today. I'm calling him. He will join now.
Okay. So
Yeah.
I'm asking the president election in Bangladesh. Today?
Yeah. Today is our national election day.
Oh, okay.
Yeah. And today is our government holiday also.
Oh, okay. Good.
Yeah.
Right.
Yeah.
So I see also Ishu joined us. So I think we can start, Professor.
I think so.
Okay, so welcome everyone to this FHU Alumni Association webinar. It's always a pleasure for me to welcome Professor Yoko Kato, who is always inspiring and supporting us. Good morning, Professor. And I also want to thank my co-moderators today. As usual, Professor Ishu Bijnoi. Hello, Ishu.
Hello.
And of course, our young colleagues, Dr. Hari, Dr. Atik, Dr. Afzal, thank you for joining us, and thank you for your help also later in the discussion. Today, we have 3 speakers. The first speaker is Dr. Tamara Yus, which I will introduce soon. The second speaker will be Professor Mustafa Baskaya, who does not need any introduction, really. And the third speaker is Dr. Arifin Samsul. They will talk about very interesting topics. Before introducing our first speaker, I would like to ask Professor Kato to give us a few words as an introduction.
Maybe in Japanese or English?
As you prefer.
Okay. So thank you very much, Professor 𝑫𝒂𝒂𝒂. We all are looking for your lecture. And today we have a very nice brainstem lesions. So we all looking for your lecture. Thank you very much.
Thank you.
Thank you very much, Professor. Before introductions, thanks also to Raja and Liu for their constant support in these webinars. The first speaker is Dr. Tamara Jus. I know Dr. Tamara Jus since a long time. She is an Italian neurosurgeon. Actually, we share our time during residency program because we are trained in the same school in Padova, Italy. She works at the hospital of Udine in the northeast part of Italy, and she's currently the chair of the neuro-oncology section of our national society. I asked Dr. Tamara Jus to join us to give a quick introduction about the brainstem anatomy, as Professor 𝑫𝒂𝒂𝒂 will talk about microsurgery for brainstem cavernomas. So I want to thank Tamara for joining us. And please, Tamara, you can start sharing your screen.
So do you see my screen?
Not yet.
Not yet. I'll try again. Sorry, because it was working 1 minute ago. I retry. And now?
Yes.
Yes.
Okay, it's full screen?
Yes, perfect.
Okay. So my personal really thank for this invitation, for the opportunity to attend this webinar, and for the opportunity to share this kind of topic with the entire faculty. So in this presentation, I will be speaking about a general overview of brainstem anatomy. The brainstem is called in this way because it recalls the flower stem, connecting the forebrain with the spinal cord. And then in brainstem, we can find different vital structures, the majority of cranial nerves nuclei, and we have many different afferent and efferent white matter tracts. Simply, brainstem consists of midbrain, pons, and medulla oblongata. Considering the time available and the complexity of this anatomical region, I've tried to divide each section, considering for each section external and internal anatomy, cranial nerve origins, blood supply, and surgical safe entry zone. The superior part of the brainstem is the midbrain. The midbrain passes through the tentorial notch and develops between optic tract and pontomesencephalic sulcus. Considering anterior surface, in the midline, we have a depression that is called interpeduncular fossa, banded at each side by the crus. If you look at the dorsal surface, we can recognize the dorsal tectum. The dorsal tectum composed by superior colliculi involved in visual reflex, inferior colliculi involved in auditory, and quadrigeminal plate. The lateral mesencephalic sulcus represents an important surgical landmark, is an important safe entry zone to the midbrain, and it separates the posterior midbrain from the anterior ventrolateral midbrain. Regarding the cranial nerves, we have the origin of the oculomotor nerves that emerges anteriorly on the medial side of the crus, and we also have the origin of the trochlear nerves. The trochlear nerves originates posteriorly. The point of origin is inferior to inferior colliculus, then the trochlear nerve surrounds the pons, passing between the posterior cerebral artery and superior cerebellar artery. If you look at internal anatomy, considering an axial section, and if we move from the lateral side to the midline, we can identify the crus that is composed by motor tracts, the substantia nigra, in which we have projection to striatum and thalamus, the medial meniscus that represent an important relay for sensory projections, and the red nucleus that carries important information regarding proprioception, vibration, and discriminative touch information. Globally, the blood supply is mainly provided by branches from basilar artery, posterior cerebral artery, and superior cerebellar artery. Anterior mesencephalic veins and lateral mesencephalic veins drains into Rosenthal veins, which in turn drains in the Gallen vein. Considering the surgical safe entry zone of the midbrain, we have to separate anterior midbrain, lateral midbrain, and dorsal midbrain. In the anterior midbrain, the surgical safe entry zone is the periocular motor zone. In the lateral midbrain, as I said, we have the lateral mesencephalic sulcus, and in the dorsal midbrain, we can consider the supracollicular sulcus and infracollicular sulcus as the safe surgical entry zones. In the anterior midbrain can be reached by using apterional or subterional approach. The lateral and dorsal midbrain can be reached by using a paramedian supracerebellar infratentorial approach. The pons is the largest part of the midbrain. Pons in Latin means a bridge between midbrain and medulla. It develops between pontomesencephalic sulcus and pontomedullary junctions. In the midline, in the anterior surface, there is a depression made by the basilar artery. If you want to explore the posterior aspect of the pons, we have to remove the cerebellum. Removing the cerebellum is possible to identify the floor of the fourth ventricle that has a rhomboid shape. And this rhomboid shape can be divided into different triangles. The superior one belongs to the dorsal surface of the pons. The inferior one, that is an upside down triangle, belongs to the surface of the medulla. In detail, in the posterior part of the pons, we can recognize different important surgical landmarks. Close to the midline, in the upper level, we identify the medial eminence. Inferiorly, we have the facial colliculus. More inferiorly and laterally, we find the vestibular area. The angle constituted at the junction between the pons and medulla is called the cerebellar-pontine angle, in which we find the cerebellar flocus, the choroid plexus. This is the point in which we have the origin of the 7th and 8th cranial nerve and foramen of Luschka. Regarding the trigeminal nerves, originates from the lateral aspect of the midpoints, while the abducens originates at the level of the pontomedullary junction, very close to the midline. Regarding internal anatomy, the pons can be divided in two different parts, but the transversing running fibers. The basilar part is the ventral part, the tegmentum part is the posterior or dorsal part. While the basilar part is a very uniform structure throughout the pons, the posterior part has a very complicated anatomy that differ if we consider section at the upper or the lower level. In the posterior part, we also find the reticular formation involved in attentiveness, and looking at the section, the midline section at the posterior, the dorsal part, superiorly, we can detect the origin of trigeminal nuclei, while in the inferior section posteriorly we have we can detect the origin, the fascial colliculus and vestibular nuclei. Regarding the blood supply, is mainly maintained by basilar artery, superior cerebral artery, anterior inferior cerebral artery. The venous system is extremely complex. We can just sum up that anterior pontomesencephalic veins drain in basal vein superiorly and inferiorly in inferior petrosal sinus. Regarding the safe entry zone, we can divide the safe entry zone between ventral lateral pons and dorsal pons. In the ventral lateral pons, the safe entry zones is represented by the trigeminal areas that can be easily reachable by using a retrosigmoid approach, while in the dorsal pons that constitute the upper part of the floor of the fourth ventricle, we can select a telovelar or transvermian suboccipital approach. Considering the safe entry zone in this region, we can identify the suprafascial zone, the intrafacial area, the acoustic area, and the median sulcus above the fascial colliculi. The medulla oblongata represents the last inferior part of the brainstem. It develops between the pontomedullary junction and the origin of the first pair of the cervical spine nerves at the level of foramen magnum. Anteriorly, we can identify 4 swellings. In the middle part, the swellings are called pyramids, and the lateral swellings are called olives. To describe, to identify the posterior aspect of the medulla, we have also to remove, as we did for the pons, the cerebellum. In this way, we can define the two different sections of the medulla: the superior half that constitute the inferior part of the fourth ventricle, in which we have the upside down triangles. In this region, we can identify the hypoglossal trigon, the vagal trigon, and the area prostrema. And then we have the inferior half of the medulla that continues with the spinal cords. In the superior half of the medulla, we also can identify in the inferior part of the superior part of the medulla of the obex that allows the fourth ventricle to continue in the central canal. And regarding the inferior half of the medulla, we can also identify at this level different sulci that allows to identify the surgical safe entry points in this region. In addition, the sulci of this region allows us to identify the fasciculus gracilis and cuneates. Regarding the internal anatomy, it's very difficult to describe the structures in few minutes. It would require an extra lessons, but we have just to keep in mind how is the position in the medulla of the cortical spinal tract represented by the blue dots, and the medial lemniscus represented by the yellow dots, because they change their position in the medulla for the fiber decussations. We have to keep in mind that the decussation of cortical spinal tract is anterior at the lower level, while the decussation of lemnisci is posterior at the upper level in the correspondence of nucleus gracilis and cuneates. Even the blood supply is extremely complex. The blood supplies change according to the section that we consider. Globally, it's supported by anterior and posterior spinal artery, vertebral artery, and posterior inferior cerebellar artery, while the transverse medullary veins converge in a complex venous system connected both with the pons and the spinal cord. The safe entry zones for the medulla can be divided in ventrolateral and dorsal medullar. For lesion in ventral and lateral medulla, the safe entry zone is represented by the anterior lateral sulcus that is posterior to the pyramid tract, and posterolateral sulcus that is posterior to the olivaril zone, and both can be reached by selecting a lateral approach. For the dorsal medulla, as we've seen previously, we have many different sulci that can be used, and all this region is reachable by selecting a median suboccipital craniotomy. I just want to conclude in this few minutes remarking the importance of deep knowledge of brainstem anatomy and the detection on the surgical safe entry zone, because combination of this information allows us to select the best surgical approach for patients with lesion in the brainstem. And here you can find the list of updated studies that I use for this presentation. And to conclude, I would like also to suggest you to look at the virtual 3D atlas of the brainstem developed by Professor Gadol. The atlas is available on Neurosurgical Atlas. And I thank you for your attention.
Thank you very much, Tamara, for this anatomical overview. Actually, I gave you not a simple task to summarize in a few minutes.
I really apologize for the speed of the speech, but it was difficult to combine all information in a few minutes.
I know it was a difficult task, but I choose the good person to make it. So thank you very much, Tamara. And of course, we postpone the discussion after Professor 𝒂𝒂𝒂𝒂's lecture. So I would like to ask my co-moderator, Professor Bishnoi, to introduce our next speaker.
Thank you, dear Alberto. So I would like to invite our next speaker, Professor 𝒓𝒂𝒏𝒔𝒂𝒂. He is a renowned neurosurgeon from University of Wisconsin School of Medicine and Public Health, USA. And he is also the director of skull-based surgery program and the cerebrovascular skull-based surgery fellowship program at the same university. His specialties are skull-based tumors like meningiomas, chordomas, acoustic neuromas, cerebrovascular surgery, and complex brain tumors involving deep and highly functional areas like limbic system. And he has published more than 270 papers and wrote 50 book chapters, and he is co-author of 2 books, Vestibular Schwannoma Surgery and Complex Surgeries of the Limbic System. So today he will be talking on microsurgery of brainstem cavernomas, and he is also a fellow from Nagoya University, Japan. So I would like to invite our speaker, Professor Mustafa, kindly present.
Thank you very much. Hope you guys can see my screen okay?
Yeah. Sure.
Perfect. And you hear me okay?
Yes, Professor.
Perfect. Thank you very much for your kind introduction, and thank you, Professor Kato, for kind invitation, and Alberto and organizing committee, and all of you for being here. Good morning, good afternoon, or good evening, wherever you are. And I was asked to talk about the microsurgery for brainstem cavernomas. Tamara did very good job, actually excellent job to summarize this complex, difficult anatomy in few minutes. So I thank her too. I have no disclosure. This is Madison, the capital city of the state of Wisconsin. And it's beautiful during the summer and spring. We welcome everybody. Anybody wants to come, and I see Temur. Temur spends a few months with us. So the brainstem cavernomas, they are, first we need to discuss a little bit about their natural history, comparing to their counterparts in the other parts of the brain. Usually they present with the focal neurological deficits, and we don't know why. This is because they're located in the highly functional areas. That's why they come to do medical attention more often than the other parts. But natural history, according to many papers, it's not good when they become symptomatic. And my own clinical experience supports this too. If people estimated, like if there's no symptom, 5-year estimated hemorrhage risk for brainstem cavernomas are around 8%. If this goes to approximately 30% if they become symptomatic. And when they become symptomatic, they remain symptomatic and they keep coming back with the small hemorrhages or significant hemorrhages. What kind of treatment options we have? Any neurosurgical pathology, my philosophy is eliminate that pathology. And this is same for the cavernomas. Cavernomas in the every other locations or in specific, particularly today's topic is the brainstem. Observation is good in certain cavernomas, and I don't see the value of stereotactic radiation or laser ablation. I have seen many patients after radiation or laser ablation remaining with the live cavernomas or complications from these two procedures. So in my opinion, surgery is the only option we have, and after the surgery is the observation in certain cases. If cavernoma is asymptomatic and the resection is relatively safe and it's on the surface, we can offer surgery to the patients. But on these cases, if it is asymptomatic, it's very reasonable to wait and see and don't take any action. If it is symptomatic, I think the cavernomas, brainstem cavernomas, should be managed more aggressively, especially the repeat hemorrhages with progressive neurological decline, definitely surgical resection. Single hemorrhage, you can wait and see if cavernoma is coming to peel surface, then you can attack the cavernoma. And if not, you can wait. But I have a couple of patients I waited in the past, and they had permanent deficits from the repeat hemorrhages. So again, it is a very tough decision between waiting and the surgery. And I think you should evaluate each case separately and individually. And the timing is also a question in the brainstem cavernoma surgery. Surgical intervention after hemorrhagic presentation can be delayed for a few days. And this is also nowadays we have not only the medical or patient-related specific reasons, but we have also in the United States problem scheduling the surgeries. So tell you the truth, sometimes I do whenever I can. Sometimes if I can, I like to wait up to 2 weeks. During that time, the hematoma solid part of the clot becomes fluidy, liquefied, and the surgery becomes much easier. If you go beyond 2-3 weeks, that cavity gets contracted and the access becomes an issue, and also resection becomes an issue. So of course, patients who have the very severe medical comorbidities can be managed conservatively until they are stable medically. And in rare cases, as we published in the past, may need emergency decompression, emergency surgeries. And goal is the complete surgical resection, and different from the gliomas or other neoplastic processes in the brainstem. This is more achievable in cavernomas. And as Tamara summarized, there are so many surgical approaches you can take, not only the craniotomies or skull-based approaches, but choosing the right trajectory to access these brainstem regions. You need to know the anatomy very well, and then you need to exercise every single option and discuss the advantages and disadvantages of each option. And you have to achieve optimal microsurgical technique to deal with these complex lesions. In the cavernoma surgery is different from the other surgeries. It's the problem, technical difficulty comes with the surgical approaches, approaching safely to the lesion without disturbing the normal anatomy. Otherwise, removing it is not as technically challenging as like other tumors. And then, if possible, this is the key, preserving the major developmental venous anomalies. And in the brainstem, if there's no any specific reason, you should not try to remove the surrounding hemosiderin stain normal gliotic brainstem tissue. So now the surgical approaches, since this was discussed before me, I don't want to spend too much time. And we also studied this. This is the study we did in the cadaveric brain stems, and we selected most common 12 safe entry zones, and these are the safe entry zones that have been described by others and the most commonly used. And what we did, and each entry zone we determined in the cadaveric brain stems and use wooden spatulas, wooden sticks, to simulate the surgical entry. And then we did the tractography with the 4.7 Tesla MRI. Results are, in each safe approach, if there is no pathology, if you are entering through the normal anatomy, and you are very close, or you are violating some nuclei, or white matter tracts, or you are extremely close to them. So, in my opinion, in brainstem, there is no safe entry zone. Safe entry zone is you created, and it's your technique, or you're getting there, and it is not safe in any pathology in any brainstem. So surgical approaches, you can do terminal transsylvian, transcavernous to the anterior part of the brainstem, retrosigmoid, anterior transpetrosal versus posterior transpetrosal, combined, far lateral, midline occipital, and supracerebellar infratentorial approaches, median, paramedian, contralateral, ipsilateral. So there are so many options. And this is the 2-point method of Dr. Spetzler, and it works in certain situations. Not every time is the shortest way the best way. So sometimes the longest way might be the safer way. So I use this, but I use my own assessment of the shortest way versus longest way in that particular patient. So not useful in every case. This is a case, the retrosigmoid approach was utilized, and this is interesting. She's 45 with the sudden onset of headache and increased weakness, hemiparesis. And interestingly, she describes that when she was at age 5, she had 2 surgeries, and she doesn't remember. They told her family parents this was a hemorrhagic lesion. So we assume it was a cavernoma, and they were told that they attempt to remove, but not complete. They remove some part of it, but not completely. Years later, 43 years later, she presents with this new onset hemiparesis. And this is, she has a large skin incision, and if you look at the bony anatomy, post-surgical bone anatomy, they perform some kind of retrosigmoid approach. And I think trying to come through the different trajectory creates another way of complications. So I thought in this case, they have done the retrosigmoid approach already. We just extend that and then remove this because it's coming to the surface. And this is the, you don't need to go through any safe entry zone. But if this was more in the parenchyma, and you can use that peritrigeminal entry zone, and that is the area between 7 and 8 nerve roots. So that's what we did, and hopefully this projects well. There was a lot of scar. We drilled bone a little more to get more ventral, expose the transverse and sigmoid sinus junction. You see here trigeminal nerve, and there's all kind of scar tissue here. It's hard to define what is what. So this is 7 and 8 nerve complex. We stimulate it. This is 5th nerve. It's difficult to see the motor root, and she doesn't have any trigeminal symptoms. So this is the scar. This is the live part of the cavernoma, and I'm trying to create a space between 7 and 8, but this lesion and scar tissue from the previous surgeries or bleeding, it create a very adherent tissue plane for me. But with the sharp dissection, and I was able to create a little more plane there. And then now we are coming to the basilar artery and the perforators here. As you see, we need to be very, very careful with these, and violation of these will be will have very catastrophic consequences. So, and this is the gliotic tissue and the ventral part of the pons, and these are the live part of the cavernoma you see. And this is the basilar artery and the tiny perforators there. So now back and forth, working between the planes. And sometimes I use this shrinkage of the cavernoma with the bipolar coagulation. And luckily, these lesions you can actually remove piecemeal sometimes. So they don't bleed that much. They are not like AVMs, or hemangioblastomas or some other tumors. You cannot remove piece by piece. And as you see here, there are different ages of the clot, different types of cavernomas, old, and this is the cavity. And we are stimulating the facial nerve, and it's nicely stimulating. And her preoperative deficits remain unchanged. And after 2-3 months, her hemiparesis improved. She had a mild V1 to V3 diminished sensation after surgery that got better. Trigeminal nerve tolerates surgical trauma much better than any other nerve, but the 7 and 8 won't. And one small note, she didn't have a good hearing to start with. So this is a gross total resection and good results. This is another case, 57-year-old with multiple cavernomas. You can appreciate in some of these images, but he started becoming symptomatic from this, and I have been following this without any obvious change, but patient becomes more symptomatic. And if patient has a if patient has a syndrome, And this is a multiple thing, cavernomas. You don't want to just attack, remove everything one you think you can remove unless they become symptomatic. So I waited and he started becoming symptomatic without any obvious change in the characteristics of the cavernoma. And this is an easy decision. This is not a difficult decision. How to get there is small posterior midline craniotomy, and under the tonsils you work. I'm going to show this video to illustrate the importance of, you can watch actually this video. Is a very old video, and that's why the colors are different and different microscope. And to importance of the preserving and identifying the normal anatomy, and this is the location you can work with your assistant, your fellow, or your chief resident simultaneously. Professor Sugita used to say, I have 4 hands. And because through the microscope, Nagashima microscopes, he used to work. So this is the developmental venous anomaly. We need to respect this, and we need to create a plane and separate the adhesions and then remove the cavernoma. Otherwise, it comes to the surface and it's not technically challenging. But again, to show you the importance of the preserving this dorsal vein, which is very prominent and very likely draining in normal brainstem craniocervical junction. So creating a plane and then the entering, as you see, sometimes when you explore these cavernomas, you realize they have different ages of the blood clot there, and it's hard to appreciate these in the preoperative MRIs. So we're going to be creating plane, preserving the normal anatomy. I didn't have a good scissors those years. Now I have Kamiyama scissors, and see the plane creating, like Spetzler mentioned, traction and contratraction to create a plane between pathology and the normal. And again, we're going to preserve these all small draining veins joining to the main vein, and this is the gliotic plane again. And in this case, it's removing an unblock is not a good idea. So you do piecemeal removal and then to achieve the complete resection. So I'm going to speed up a little bit. So this is the most superior aspect again. And I like to use in any surgery spreading motions or cutting or peeling technique. I don't have any dogmas in I use only one, and this is the final product showing the pica loop is preserved, developmental vein is anomaly preserved, and the normal anatomy is preserved as much as we could. Of course, surgery is a trauma, but our goal is to minimize that trauma and have a good results. And this is another drastic case, and waiting and seeing. Actually, I wasn't following him. He was followed in Chicago area and was enrolled in a study to prevent using the beta blockers to prevent the repeated hemorrhages in the cavernomas. Young, very functional person becomes densely hemiparatic and keeps every few months he keeps bleeding, and finally came to my clinic for another opinion after he obtained like 1 million opinions. So I told him he shouldn't wait anymore because his hemiparesis is getting worse. We scheduled the surgery. Few days before scheduled date, he presented with another attack, and he became very hemiparatic, almost hemiplegic in the arm, pelagic in the arm. So waiting is not good in these cases. So you go ahead and attack the cavernoma right away. Don't wait too long. And this is the case actually showing you there's a variation of the bony anatomy here. I prefer far lateral approach. There was an arcuate foramen, the bone covering the vertebral artery at the V3 segment. So then once the approach is done, you want to be as ventral as you can. And this arcuate foramen, I had to drill a little bit that bone to see this way, ventral to the brainstem, because that's where it is coming to the surface. Ventral lateral, anterolateral part of the medulla. You see that region, and it's anatomically, if you study well the T2s and the diffusion tractography, this cavernoma is very, very close to the corticospinal tract. So we'll do all kind of monitoring here, lower cranial nerves plus MEPs and SSCPs. And as you see, it is not easily coming because waiting multiple hemorrhages create this contraction of the tissue, fibrosis of the tissue. And then dissecting is not an easy, and you don't have a good angle in these cases to see 100%. So sharp dissection and being patient and very frequent runs of the motor evoked potential. You don't want to cause a harm. And if there's a decline in the motor evoked potentials, I think you should rest, see if they are not coming back, you should stop it. And so again, small pieces of the fibrotic tissue, small pieces of the live cavernomas, and some of the parts they die, but then they become after each hemorrhage, and the other small live ones produces the new cavernomas. So again, traction, not too much with one hand. The other hand is your sharp dissection. And when you use bipolar coagulation in the brainstem, if you have to use a smallest intensity, and this is the final view after removing it. Immediate postoperatively he was same, but like day 3, day 4, interestingly, he started improving. His hand is almost pelagic, and now he's functioning near perfectly fine. And he's young. In a year time, he's going to be perfect. So young people, I think we shouldn't wait. We should be more aggressive after repeat hemorrhages. This is another one, 50-year-old. The approach here, you can discuss many approaches. I chose transcavernous and drilled the petrous apex a little bit. That gave me a freedom, and I'm not going to spend too much time on that. And we did the removal again, multiple cavernomas, and one of them was becoming very symptomatic. So surgery is the only solution in these cases. This is a peduncular lesion and the mesencephalon, and the best approach here is not subtemporal, just coming longest way, and that's the paramedian supracerebellar, and that will get you to the lesion. It comes to the surface in one aspect here, and that's going to be your entry point. You should not entertain anything else. And this is the paramedian supracerebellar approach to do this cavernoma. This is another one, again, using the fourth ventricle, if possible, unless they are coming to the surface. I don't like using the fourth ventricle route because, as Tamara showed, this is a very tight area. There are so many important structures, and you have to use the mapping in these cases. Again, if there's no other option. Okay, you have to go through the fourth floor of the fourth ventricle. But in certain cases, you can use the lateral route instead of coming from the floor. So this is the case, again, growing and becoming more symptomatic, median suboccipital craniotomy, and preserving the arachnoid of the cisterna magna is important. Again, here is the televelar approach or cerebellomedullary fissure approach, is just being patient with it, mobilizing the pica away from your entry and cutting the tela and going between uvula. Now I'm between uvula and the tonsillo-uvular approach. So it's entire thing actually arachnoid. We don't need to give strange names to these. This is cerebellomedullary fissure. There are different parts of it, and getting there, freeing it so you can do safer approach. And I'm retracting the tonsil here a little bit, but this dissection reduces the retraction forces in the tonsil, and you can retract the tonsil without any difficulty. So again, there, go. So we are coming to where it is coming to the surface here. And here I'm going to map the facial nerve, and I want to be below the facial nerve, and that comes to the surface right away. From that point is removing that, not technically challenging. And believe or not, his facial palsy and the 6 nerve deficits were same as before surgery, but he had a strange oropharyngeal weakness, which required temporary feeding tube placement for a few days, and then he's completely normal now. So that is the show you do to the fourth ventricle, floor of the fourth ventricle. This is very recent, very dramatic case again. Previously very healthy 22-year-old woman presented with sudden onset of very severe headache and sensory changes, hemibody, and the hemiparesis. So this is first time coming to the medical attention. And there's no point waiting here and wait to get that hematoma liquefied and operate in the next few days to the up to a couple of weeks. Don't wait longer than that. It's going to contract it, and it's going to make your surgical removal more difficult. And this is retrosigmoid approach and small, not very big craniotomy, but you need to expose transverse sigmoid sinus junction well, so you have a ventral, and the cerebellum is always full in these cases. And bring your microscope and put your pedis, retract the cerebellum laterally a little bit to open the arachnoid of the lateral cerebellomedullary cistern. That will relax the cerebellum immediately. Then I always put surgicells over the lateral cerebellum, and then is the arachnoid dissection as usual for other pathologies, for any pathologies we do, freeing the lower cranial nerves first, and then moving up towards the 7 and 8, freeing the 7 and 8, and that will allow you to retract. And you see the flocculus here for the young colleagues, and this is 7 and 8 nerve complex, and prominent suprameatal tubercle there. And that's our trajectory. Again, I'm showing the lower cranial nerves, 7 and 8, Ica loop, dandy veins, 5th nerve here, robust nerve, and then the motor root of the 5th nerve and tentorium. Stimulating and finding that so-called trigeminal area, and there is a prominent vein there, mobilizing that vein away and entering to the pons and a small point. And then the rest is just removing the pathology. If you had a tumor here, it's going to be more difficult, but it can be done. I do the brainstem gliomas through this location too, and as well as the cavernomas. So we're going to enter, is not close to the surface, and you are here and you see the first fresh hematoma. And then even though she didn't have any symptoms, she had different ages of the clot. So we're going to remove. I'm sorry, I'm just speeding up for the time reasons. And this is the end of the case and suturing it. Believe or not, she had a wonderful postoperative course immediately after surgery, because her headaches and the diminished sensation got better immediately. Her hemiparesis was same, but then she remained perfectly fine, and then she was discharged to rehab. Now she's living normally after a few weeks of the surgery. And this is another recent case. It's hard to say this is a mesencephalon or thalamus or both, but the approach is same as the I showed you before. Again, I'm going to come supracerebellar paramedian approach, and this is the approach. I hope I have time. Do I have time, or should I stop?
You can go ahead, Professor.
This is going to be the last. So I'm not cutting the tentorium here. This is not a transtentorial approach. Tentorium had a fault that prevented me to see better. I just cut that part. I'm completely supracerebellar now, and this is to show you the anatomy. And interestingly, in this case, the parahippocampal gyrus, part of it is herniating through the tentorial incisura, so you have to mobilize that. That's what I'm talking about. This is a parahippocampal gyrus and PCA branch there. I need to mobilize to get to the surface. So cavernoma surgery is about getting there safely, and once you enter the pathology, removing is not that challenging. So you see the dense network of the arteries on the brainstem surface, and I'm trying to, yes, here you see that discoloration and the most cortical representation of the cavernoma. So what we're going to do, we're going to remove these tiny arteries away from the cavernoma, away from where I'm going to enter. Then once you enter, removing piece by piece and patiently. Don't rush it. It's your time, and this is a sacred time between you and the patient. Okay, that's it. The getting there didn't take too long, and entering, and that's going to be the perfect case and perfect results. Good, and we eliminate the pathology. And she didn't move a bit. She was discharged from day 2. And emergency surgeries. Yes, in certain cases like this, you have to do emergency surgery. This is 24-year-old man. Okay, this is when they called us in the referring hospital. On arrival, few hours later, comatose, quadriplegic, lost gag reflex. Don't wait on this. Look at this. Yeah, he's gonna die. So we took him to the surgery, retrosigmoid approach, pre-op, post-op, and he got married. He's living normal life now. Same emergency surgery, supracerebellar approach. This is 1 week after surgery. This guy was GCS3, no corneals, nothing. So in certain cases, you have to do emergency surgery. So in conclusion, in my opinion, surgery is the only way. In some rare selected cases, you can try laser ablation or stereotactic radiation if you are desperate. But we as neurosurgeons, we are not desperate. We have solution for this, so we should do surgery. Why? Eliminates the problem, eliminates the bleeding risk, and increases the chance of recovery from preoperative neurological deficits. So that's my conclusion. And at the end, anatomy is everything. Anatomy for correct localization, anatomy choosing the correct surgical approach. And these are the 3D pictures Professor Yaşargil used in 1953. Okay, so he dissected 400 hemispheres. That's how he became so good understanding this 3D anatomy in his mind. This is our laboratory. We welcome everybody. And before you perform these surgeries, you should go listen to the masters, see the masters, like you guys are doing it, right? You are following a legacy of Professor Kato. You see her every day talking to you guys, teaching you guys, and then you remember. And then when you do these techniques in the lab, you understand better. So thank you if I took so much time. And again, I'm honored to be with you guys here. I'm happy to take any question if you have any.
Thank you. Thank you, Professor, for this wonderful lecture. And now the panel is open for the discussion. And there are two questions. Okay. So, Dr. Farhad, Dr. Hari.
Hello. Thank you, Professor, for your excellent talk. I learned a lot from your presentation. So I just wanted to ask one question regarding waiting. You said you will wait in some cases for a few days. So what is the idea behind waiting? Is it to reduce the edema, or I just wanted to know?
So I think I mentioned that briefly. So if you wait up to 2 weeks, Dr. Roberto used to say this also. He used to mention this very often. Clot, initial few days, clot is firm. Okay, hematoma is firm. And then it becomes fluid, liquefied. And that fluid make your dissection, microsurgical dissection and removal much easier. And if you wait too long, that goes away and the cavity becomes contracted and fibrotic. If you open the subdural hematoma acutely, unless it's actively bleeding, is firm clot there you see, right? But if you wait up to 2 weeks, that becomes a more liquefied, much softer and easier to remove. That's the only reason I wait for. But certain cases, by waiting, edema actually increases over time too. So you need to make decision, okay, edema will increase or hematoma will be more softer, much softer. So that decision, I always like to make it, I like to wait up to 2 weeks, not more than 2 weeks. But same time, logistics, right? You cannot schedule the surgery. You have to do it 3-4 days after the initial bleed. It's not a big deal. You can do it.
Okay.
I mean, I hope I answer your
yes.
correctly.
Thank you, Professor.
You're welcome.
Thank you.
Dr. Farhad.
I am Dr. Farhad. I have 2 questions actually. Tremendous lecture and tremendous outcome of those patients. I have one question, that is, do you use any paraoperative endoscope to see any hidden areas or any difficult areas to inspect? Number 1. And number 2 is, what is the protocol of ICU management after the surgery? Do you use the protocol that patient can be reversed after surgery, or you electively keep the patient on ICU? Thank you very much.
You're welcome. So I'll start with the second question. Yes, all these patients go to ICU. I mean, any craniotomy we do, this is University of Wisconsin protocol. Even the small metastatic craniotomy, we send them to a couple of hours in recovery. They call it PACU, post anesthesia care unit, and then from there they go to neuro ICU, and we extubate these patients right away. We don't keep them intubated, and then all depends on after the first one night stay in the ICU. All depends on how they are doing, and also we do MRI right away after next 24 hours. And if MRI looks fine and no concerning findings in the surgical area or the approach you did, there's no subdural, no epidural, nothing, everything looks clean, and the patient's preoperative deficit same, and we just proceed with the intermediate care or general care. But one exception is the lower cranial nerve deficits. So you need to be cautious about those, because you can have aspiration pneumonia for those patients we suspect, or patients has preoperative dysfunction of the lower cranial nerves, or swallowing, or voice, or anything like that, or a pharyngeal apraxia. We subject them to do video swallowing test and then proceed accordingly. That's the answer to your first question. A second question. And the first question was using the endoscope assistance. Yeah, why not? I use sometimes, rarely I use, but if you have any suspicion, you should use it.
Thank you.
You're welcome.
Yeah, we have other questions, Dr. Atiq, or yeah.
Yeah, thank you, Professor, for your brilliant presentation. Basically, we learned a lot from this lecture. On simple question, in most of the cavernomas that bleeds, we get a clear margin of dissection. Do you think that dissection along the margin creates little bit traction on the brainstem, and we can do piecemeal resection of the cavernoma and central decoring followed by going to the margin? And what technique do you suggest better, that total removal of the tumor by resection along the pia, or just piecemeal removal of the cavernoma and then go to the bile surface? Which technique is better from your perspective?
I think, in my opinion, there's none of them is better over other one. You make that decision in that particular case. So I show you one case. You have to do piecemeal resection, because there's no way going around. If these are not very large lesions, but you are working through a very narrow tunnel, and it looks like a very large in the high magnification, right? And then you need to make it smaller if you want to see better. But one case I showed you, retrosigmoid approach, previous surgeries, and in that case, I did unblock, because I felt like doing that is going to be better. So your sense at that time, and your skills you gain over years, experiences you gain over years, and seeing these and using the previous experiences, you make that decision at that time. If necessary, you go remove unblock. If necessary, most of the time, everything we do in neurosurgery is traumatic. Okay, we are not. You cannot tell. I'm super careful. I don't touch this. I cannot touch this. You develop that tactile sense, how much to pull, how much not to pull during these surgeries. Okay, and each time you improve. So if I tell you I clean pia arachnoid of the cadaveric brains, hundreds of them, to develop this sense. Okay, I went to the lab. You know that beautiful roton pictures? You see dissections, vessels, veins, and arteries. You know how much time they spent to peel that arachnoid, P arachnoid, to clean, to give you that beautiful picture. Hours, days. But you develop that size, how much traction you can apply, how much contra traction you can apply. It didn't come to Spätzle right away overnight. That sense, oh, God sent me this skill, I can use it. No, it spent like years to develop that skill. So yes, some cases, piecemeal resection, some cases, if you can, en bloc resection. Small lesions usually enables you to do the en bloc resection. So this, I don't know. I'm giving you the right answer, but it comes over time.
Yeah, and it is case based.
Correct.
Every case is individual and decision is individual, right?
Exactly.
Yeah.
For
Thank you.
example, if you are doing brainstem glioma, is completely different pathology. You cannot remove en bloc.
Yeah. Thank you.
Thank you.
Thank you. We have Dr. Biswas.
Thank you, sir. Excellent lecture. If you allow, I have a couple of questions to ask. Sir, for the emergency evacuation of cavernous malformation, if the GCS is 3-4, how many hours you consider for the emergency evacuation? I mean, sometimes patient presents lately with GCS 3 and 4. So how many hours you consider within which you go for the emergency evacuation?
Yeah, as soon as you can, because this patient didn't come to University of Wisconsin, went to 4 hours, 5 hours away in another hospital, and they did the CAT scan and MRI, and he was densely hemiplegic at that time, and in few hours after he came with helicopter, he was quadriplegic. So you don't have much time anymore. Okay, you have to proceed immediately. It's telling you I'm not going to be a steady, stable case. So 1 week of headaches, then hemiplegia at the presentation at the other hospital, and becomes quadriplegic on arrival. And we don't know he became quadriplegic on arrival or he became quadriplegic in the helicopter. They intubated him, they paralyzed him, we woke him up, he doesn't move anything. And he's gone, he's dying. So you have to do something in 24-year-old. You say, hey, okay, I'll give steroids, I'll wait. It's not going to work. This is a neurosurgical emergency now. Like you're acting for epidural or subdural, you have to do it something now. And we published these 4 cases, actually now more than 4, in Journal of Neurosurgery. And the reviewers act like this is something new. It's not new. People do it, but they didn't think it's publishable, 1 case, 2 case. So emergency is emergency. Okay, you don't wait. But you are a neurosurgeon. That's why you train this long, this many years, and you do residency, you do fellowship, you go see the patients, you join these meetings to make these decisions in the right way.
Exactly. Very much encouraging, sir.
Not all, do we make this decision always right way? No. I mean, I still sometimes say, oh, maybe we should wait another day or something, and then patient deteriorates.
Okay. Sir, one more question, sir. If anteriorly placed pontine cavernous malformation, do you consider going through endoscopic intranasal transclival?
I don't. If that's the case, if I think that's the only safest way to approach, I will ask one of my endoscopic surgeons to perform the approach and then the surgery. But yeah, whatever is safest way, I will take that route.
I mean, comparing with the transcranial approach you have shown, do you have any comparative experience of the outcome between the endoscopic versus transcopic?
I don't do endoscopic approaches. I'm not against them, but I don't do it. I have junior partner. I'll give them to those cases to him so he can improve.
Oh, okay. I have one last question to Dr. Tamara regarding the anatomy. Can I ask her the questions?
Sure, of course.
Yes, sure. Tamara, are you
Dr. Tamara,
fine?
it was an excellent presentation, recapitulation regarding the brainstem anatomy. I have just one question regarding the anatomy of the floor of the fourth ventricle. I have one confusion regarding the location of the facial colliculus. Is there any geometric measurement of the location of the facial colliculus in relation to stria medullaris?
Yeah, Tamara, are you online?
Hello. Hey.
Hey, we're good to go for this case with Bev at 7:30.
Yeah, but this is just angiogram, not.
Dr. Tamara,
not
kindly unmute yourself.
Tamara, you should unmute.
Unmute yourself.
Sorry, do you hear me?
Yes, now we can hear you.
I didn't have a good connection. Could you repeat the question, because I heard just the last part of the question.
Yes, so I think the question was right, the position of the facial colliculi compared to the medullary striae, right?
Yeah, stria medullaris. Geometric measurement rather than the elevation of the median eminence, because there is quite variation in the location of the facial colliculus.
So in my knowledge, I know that there are maybe some preliminary investigation by using stratigraphy, but by using the normal scan, it's not possible to achieve a good quality of image to investigate these relationships. Maybe there is some preliminary results by using the 7 Tesla stratigraphy.
Oh, okay. Can we also use the neuromonitoring parameter for the location as well?
About the neuromonitoring, the intraoperative neuromonitoring to localize the collicula.
Yeah. Is it possible?
You have to, in the experience that I have, you can just identify the nucleus, but it's also depend on the preoperative functional level. But if you have a dedicated neurophysiologist, maybe you can reach this information.
Yeah, if I may,
You require a
possible, yes.
neurophysiological dedicated unit.
Exactly. So you need to have a good neurophysiologist and you can locate it. And from an anatomical point of view, of course, you have to take care of the relationship between the facial colliculus, which is more cranial compared to the acoustic striae, looking at the surface of the fourth ventricle. But sometimes it's not so easy to identify the striae because they are really very tiny structures. Yeah. Thank you, Dr. Biswas. Thank you, Tamara, for the answer. I think we should go on with Temur.
Thank you for excellent lecture, Dr. Bashkaya. And I want to also thank for the fellowship last year. It was amazing and great skull beats and cerebrovascular lab. Also very complex cases in the OR. My first question is, when you remove the cavernomas, do you put some hemostatic in place of that cavity? And the second question is, what is your approach in very young patients, asymptomatic patients, and also very old patients, asymptomatic patients with cavernomas? Do you like, for example, be more aggressive in young patients and more like conservative management in older patients? Thank you.
Thank you, Temur. Good to see you again. So you said symptomatic or asymptomatic?
Asymptomatic.
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 Symptomatic symptoms patients discovered incidentally, right? Yeah, young patient, you don't have to do anything, you know, it's just you can wait and see how that cavernoma is going to behave. And also the multiple versus single, and syndromic versus non-syndromic. So if you suspect this cavernoma is an active lesion, and you see that multiple different ages of the bleed, then you can be aggressive if patient is young and if it is coming to the surface. Older patients, I think I will be more conservative in asymptomatic patients.
Yes, thank you. And about the after removal, do you put
Hemostatic agent? If I will put a little Surgicel or little gel foam or something, but most of the time they are not like a tumors. They don't bleed much after you remove it. If you keep that gliotic plane, and most of the time you don't need to put anything. You just low intensity bipolar or no bipolar at all. You just compress and wait and irrigate. But if I'll use very small piece of Surgicel or gel foam. If you put too much, and it gives you it collects the blood there, and I see this in the post-tumor resections. It gives you the impression that there's a contrast enhancing tumor there.
Thank you. Thank you very much.
Thank you. Thank you. Before moving on, I see we also have connected Professor Vincent Ng, who is chair in the Singapore Neurosurgical Department. I don't know if he's online and wants to give us a comment on this. Professor Vincent.
Hi, good evening, everybody. Sorry, I'm actually in the middle of traveling, but joining the. But I have a question for Professor. Really asking. I just want to find out regarding the interpretations of the cavernoma and the hemorrhage itself. Sometimes the difficulty I personally face is that the clot may have come to the surface, but the cavernoma remains fairly embedded within the brainstem substance, and that's some difficulty. And just want to find out whether, in terms of the interpretations of the images, and which sequences would you look at it most carefully on deciding on your approach? Thank you very much.
Thank you. I look at all the MRI images from T1, T2, T2 star, flare, tractography, and anything I can use to interpret the bleeding, ages of the bleeding, or guess how many bleeding this patient may have. But to determine whether or not patient had a bleeding, I think the clinical symptomatology, new symptoms are I think more important. So for surgical approaches, I look at every single image I can to find how close to the surface, peel surface. T2 star images, it can be sometimes you see very dark, it's coming, and not I always find useful to see that images. T2, T1, you know, it's always there's a distance, and then the MRI, I think, exaggerates the distance, and then you feel like, oh, this is coming to the surface. You explore, actually, there's a few millimeters of the brainstem tissue. But again, you are making guess, so it's 100%, but it's coming to the most closest part to the surface. You are choosing that trajectory. Did I explain okay, or?
Yes, thank you very much. Thank you.
You're welcome.
Thank you. we have the time for the very last question, Professor 𝒂𝒂𝒂, Dilshad.
Yes, thank you so much, dear friends. Professor 𝒂𝒂𝒂, thank you so much. Teşekkürler. Just one question. It's a continuation of the question of one of our colleagues regarding the piecemeal resection and en bloc resection. When you do piecemeal resection, does it cause more bleeding versus en bloc resection? Or there is a special technique how to do a piecemeal resection, and especially in cavernoma cases?
Yeah, cavernomas are not super bloody cases. You know, even if you cut through so some parts of the lesion is fibrotic contracted tissue, and you don't know that was a cavernoma that bled before and now it's not alive, or part of the hematoma formation, or what, you don't know. So if you cut through that tissue, it doesn't bleed. But if there are live parts, you can see like they look like a blackberry or little berries, right? If you cut those, it's gonna bleed, and you can just easily stop that bleeding with the bipolar coagulation. But there are certain cavernomas bleed more than the others, and this is not always the rule. So you need to be very well prepared and see how live, how red that tissue looking to you. And then you can just use like a bipolar to contract that tissue by coagulating, making it smaller, like you are doing the meningioma, right? You coagulate the meningioma tissue, you are contracting that, and that deflates the tissue and vascularity, so you are gaining space to see a little better. You can do that if you think you cannot cut it, but you develop that sense over time, and if you feel like you can cut it, you cut it and remove it. It's not going to bleed that much. I mean, if everything bleeds, but you can control too with bipolar. It's not like you are cutting the hemangioblastoma or AVM. Okay, hemangioblastomas are the AVMs, are the most. I mean, if you cut through the nidus or hemangioblastoma without taking this feeders, it's going to be bloody, and you won't be able to stop it.
Okay, thanks so much.
You're welcome.
Thank you, Professor 𝒂𝒂𝒂. Issue, I think we should move on to the next speaker, if you agree. And I want to thank Professor 𝒂𝒂𝒂. And of course, if you can stay with us for the second lecture, we are more than happy. But we don't want to abuse of your time because we know it's very early in the morning in the US. So thank you very much.
I'll try to stay, but I have to review a case. They just called me about a ruptured aneurysm. So
yeah, sure. If you can, okay, we are more than happy. If not, thank you very much again for.
Thank you again. Thank you all. Thank you for the kind invitation and wonderful questions and very interactive discussion. And thank you, Professor Kato.
Thank you so much.
See you all again. Thank you very much.
Okay, let's see you again. I think that you showed us a very how do I say it, many important points, because so decision making and anatomy, and also the timing of the surgery, and also the exposure, and also the surgical skill, everything you talked. So it's very helped the young doctors, the future. Thank you so much. All the best.
Thank you.
To the 2-4. Thank you.
Same. Thank you. Bye-bye.
Thank you. Ari?
Yes, Professor.
Yeah, maybe we can move on.
Yes. So we'll move on to our third speaker. Today we have our third speaker is a young neurosurgeon from Bangladesh, Dr. Shamsul Arfin. He is currently working as a neurosurgeon at National Institute of Neurosciences, Dhaka, and he has a special interest in vascular surgery. and he has already done considerable work. He has performed 150 microvascular anastomosis and clipped around 250 aneurysms. So today he will be presenting on revascularization in Moyamoya disease and his early experiences. So the floor is yours, Dr. Arkin. Yeah. We welcome you. Yeah, we can see your screen, but the audio is not audible.
Hello. Can you hear me?
Yes, we can hear you.
Thank you very much. Respected Iyoko Sensei, organizers of CNS of this conference webinar, and neurosurgeons from home and abroad. Good afternoon, good evening. I'm Shamsul Arifin. I would like to share my early experiences of on revascularization in Moyamoya cases. So we all know microvascular bypass is a surgical technique that enables us to treat varieties of vascular and non-vascular pathologies efficiently. In cases of Moyamoya disease, for pediatric patients, both direct and indirect bypass leads to satisfactory outcome either in combination or separately. But in adult age group, it is advised to do direct bypass. We are grateful to Professor 𝑔𝒂𝒂𝒂, father of modern microneurosurgery. He did first 𝑠TMCA bypass in a case of ischemic stroke due to ICU occlusion in 1967-19. And in 1972, he did first 𝑠TMCA bypass in a Moyamoya case. So I have dealt with 25 cases from April 21 to December 23. In this almost 3 years, I have dealt with 15 cases of young patients and children where both direct and indirect bypass was done. In 10 adult cases, only direct bypass was done. Out of 25 patients, 9 were male and 6 were female. Bilateral revascularization was done in 12 cases. 𝑠TMCA bypass was done in different combinations. In most cases, 15 cases, single 𝑠TMCA bypass was done. Single vessel double anastomosis, that is 𝑠haRBL bypass was done in 5 cases. Bilateral treatment in a single setting was attempted in 2 cases. And in separate stage version, bilateral treatment done in 10 cases, using 2 branch of frontal division for direct bypass in 1 case, and double barrel 𝑠TMCA bypass was done in 1 case. So let's see some of the cases. This is first case, 9-year-old boy admitted with completely aphakic, non-communicable, don't follow any command, both weakness more on right side. In angiogram, we see the bilateral supraclinical IC stenosis, and there is an impact on left MCA areas, MRI showing similar findings. So we have addressed the left side first. We did left-sided direct 𝑠TMCA bypass with encephaloduro-arteriomyosynangiosis. Post-op scan showing this is the areas where the muscle is inserted, but immediate post-op scan showing no significant change of vascularity. But at 7-month follow-up, we can see there is an increased vascularity in the areas of where we have tried revascularization. And in 9-month follow-up, in post-op CT angiogram, there is a significant change observed. There is deep temporal artery, multiple branches from the deep temporal artery through myosynangiosis and through 𝑠TMCA bypass frontal branch going inside, and a parietal branch which was kept in continuity with the skull going inside for vascularization. In coronal CT angiogram, we see the multiple cortical vessels in MC areas from revascularization, which are lacking on the contralateral side. So at 10-month follow-up, we planned for revascularization on the right side. So this is the right side of the patient. This is front, and this is the back of the head. The front STA frontal branch and STA parietal branch. The galio-pericranial tissue are kept in continuity with this parietal branch, and we have dissected this galio-superficial temporal fascia layer from the deep temporal fascia and the frontal branch. The frontal branch disconnected for direct anastomosis, and parietal branch rolled out. Temporalis muscle is deflected forward, and then we did the craniotomy, preserving the middle meningeal artery. And after durotomy in a stellate fashion, direct 𝑠TMCA bypass was done. And in multiple areas, arachnoid was open for indirect synangiosis. So after direct anastomosis, that gallio-peritoneal flap was sutured with inverted dural margins to fill the gap and for synangiosis as well. The operative video. STA was prepared, fish mouthing was done, stained with gential violet. See the brain after dural opening. It is oligamic. The arachnoids are thick and less transparent than a normal brain. And those are sharply cut to expose the recipient 𝑚4 vessels. So this is the recipient 𝑚4, which is tiny as well as thin. Arteriotomy was done. Before temporary clipping, STA frontal branch was preloaded with 10 nylon. First heel stitch was sewn with 4 to 5 knots. Then toe stitch was given. After completion of toe stitch, running continuous fashion, lateral wall was sutured, and then the medial wall was sutured in similar fashion. So after completion of both walls, hemostatic agents was placed along the margins of the suture, and then after completion of the direct anastomosis, more areas were open, arachnoid opening was done. To the bypass. So patient was discharged without any deficit, and this is the post-obiscine no new infarct with bilateral revascularization. This is a 5-year-old kid, left-sided weakness, repeated episodes of convulsions, and involuntary choreoform movements on the left upper limb. We see that there is an infarct on the right side. And if you see the angiogram, there is a significant stenosis as well as advanced myoma grade, extensive basal myoma on both sides. We did right-sided FHU bypass plus indirect bypass as well. This is the right side. This is the front of the head, and this is the back of the head. This is the frontal branch, which abnormal course because there is a major branch here. So we cut the frontal branch and brought it to the field below the superior temporal line. Usually it goes like this. And we did the STA 𝑚4 bypass about the sylvian fissure. This is the peritoneal flap, gallio-peritoneal flap containing the parietal branch for indirect bypass. So this is the operative video after completion of the bypass. So this is the STA 𝑚4 bypass, well versatile. We did a paraoperative fluorescein angiography. We see the patency of the bypass. STA will be visualized earlier than the brain cortical 𝑚4, and bypass is patent, and later part the cortical area is illuminized. So this is the parietal branch, which is viable in the pericranial flap. And this is the post-op scan. Post-op scan showing the oil patent STA 𝑚4 bypass. And a 2-month follow-up patient has already improved clinically. This is a story of 3-year-old girl presented with right-sided weakness, left MC areas infarct. If you see the angiogram carefully, in both areas, there is a supraclinoidal IC stenosis, stenosis on both sides, ACL less affected. In this case, we did left-sided combined direct and indirect bypass, including myosynangiosis. And immediate post-op scan, there is no significant change, basal myoma present. Patient came to us for follow-up at 1 year. We did CT perfusion. CT angiogram at this point revealed the blood vessels in the vascularized side that we already done. Left side is very good compared to right side. There is increased basal myoma in this zone. So you see the axial angiogram and as well as coronal angiogram. There's extensive basal myoma on right side, but in the operative side, the vascular is normal. We did perfusion, cerebral blood flow is reduced on the right side, blood volume is almost normal or more than normal. time to peak and time to drain is increased on the right side. So we planned for revascularization on the right side, but unfortunately, this girl fall victim to a burn injury in leg, and surgery was postponed. So at a 2-year follow-up, we see at this time the MC areas is gone, totally gone, and Mohammed vessel is also decreased. At the time of first surgery 2 years back, both MC areas were there. Patient came to us for surgery as 2.5 years. That time, angiogram revealed the direct and indirect vascularization is intact, MRA, and no MC vessels. 𝑦𝒓𝒊𝒏 is there. So we did right-sided 𝑠𝑡-𝑚𝒂𝒏 bypass. So this is the right side, this is the nose, and this is the back of the head. This is the frontal branch going for direct bypass. This is the middle meningeal artery. We kept it patent and make Chinese road like Professor Binzu and did indirect bypass. So this is the operative video of this surgery. Brain is not that much oligamic like the previous video. The ST was prepared in a similar fashion with fish mouthing. Arachnoid was open in sharp fashion. In this sort of brain, sulcal M4 is too much thin, deep, and fragile. So meticulous decision is required to make it viable for bypass and to make it superficial. It was stained with gential violet. Preloading of the ST was done with 10 nylon, first distal clipping and then temporary proximal clipping for trapping it, arteriotomy with adequate size matching with the fish mouth of the STA, and then first heel stitch was given with 4 to 5 knots with 10 nylon. After that, toe stitch, and then later was sutured in interrupted fashion. 4 stitch was given. Then the STA was flipped towards opposite direction for easy suturing. Another 4 stitch was given in the medial side. Then the stitch margins was covered with surgical and gel foam, and bypass was active. This is the post-op scan. The baby was all symptoms free at the time of discharge after second surgery and well vascularized. This is the case of 2-year and 9-month-old kid, right-sided hemiparesis. This is by far my youngest kid where I did 𝑠𝑡-𝑚𝒂𝒏 direct bypass. There is a large MCA area infarct. We did surgery after 6 weeks later of this infarct. There is vascularity is reduced on the right side as well. Left side, sorry. We did left-sided combined bypass. As direct bypass may not be feasible, large area of craniotomy was done. This is pericranial flap and STA for frontal branch. See the brain. Brain is oligamic like the first case. And after bypass and after CSF drainage, the brain is more reddish at the end of surgery. The dura was inverted, which was opened in stellate fashion. And the big area was covered in all possible manners. Like in the posterior part of the area is covered with pericranium containing the parietal branch of the STA. The direct bypass is going like this, frontal branch. The anterior area is covered with pericranium containing vascularity from the supratrochlear artery, and middle area is covered with the temporalis muscle containing the deep temporal arteries. So all possible bypass is given. Extensive bypass. This is the branch keeping the scalp. And this is the patient at the first. This is the post-op scan. The direct bypass is well visualized. ST is robust. This is a 4-year-old kid, recurrent right-sided limb weakness. If you see here, there is a left-sided AC territory infarct, but if you see the angiogram, MC area is almost vanished, and only PC area is prominent and the distal part of the ACL. We planned for extensive revascularization in this case. With single setting, we did left-sided frontotemporal craniotomy with combined bypass in MC areas. In the AC areas, parasagittal craniotomy with encephalate duroperiosteal synogenesis, and retracting the skin flap through same incision crossing midline, we did multiple bar holes. So this is the direct 𝑠𝒌 bypass, 2 craniotomies and 3 bar holes. This is doing well. This 9-year-old girl presented with cortical blindness and Anton syndromes. She has denial. She can't see, but she can agree. If you see, she has occipital infarct on the right side, but if you see the angiogram, the PC areas is almost intact, but maybe due to some steam phenomena, there is a occipital infarct. We did revascularize the right side first, right side single _STMCA bypass. In second setting, we did left side 1 vessel 2 anastomosis, and at follow-up, this is the scenario. Both bypasses, direct bypasses intact, and patient is doing well. Now the vision improved to hand movement, Anton syndromes gone, and cognitive function significantly improved. So this is another unfortunate patient presented with aphasia, bedridden, fed with NG tubes, non-communicable, all 4 limbs with weakness more on right side. There is a left-sided more significant infarct. We did the angiogram revealed supraclavicular ICA stenosis with gross perfusion deficit on left side. First, we did left-sided STMCA bypass and STMCA bypass, but in this case, we did 1 vessel 2 anastomosis like Professor Charbel. So in 1 vessel 2 anastomosis parietal branch, we kept it for indirect by component, and for direct component, this frontal branch utilized for 2 anastomosis. First, proximal part for side-to-side anastomosis, and distal part for interside anastomosis. For side-to-side anastomosis, proximal part of the ST was prepared, then distal part of the same vessel fish mouthing was done with stain. So for 2 anastomosis, we like to do it 1 below the sylvian fissure and 1 above the sylvian fissure. Both M4 was prepared. First, we performed the side-to-side anastomosis with proximal part of the donor STA. So like jejunostomy, side-to-side anastomosis was done, first inner layer and then outer layer in a running continuous fashion. So after performing side-to-side bypass and ensuring patency of it through the distal end of it, we clipped and performed the interside anastomosis with same branch. This is the immediate scan. See the size of the STA. It takes almost the caliber of the ICA, and this is the side-to-side anastomosis, and this is the end-to-side anastomosis. We did surgery on the right side, single STMCA bypass. So immediate post-op DSA at 7 days after the second surgery, the fresh anastomosis is like this, and the left side it's 1 vessel 2 anastomosis is mature, and no single bypass can be head can be identified. Rather, whole MC area is vascularized. So this is the follow-up after second surgery. Patient is doing well, can take care of himself, follows commands as well as witness improved. In some cases, in one case actually, we did STMC double barrel bypass. Patient presented with post-pre MC area, old infarct with new onset occipital area. So we wanted to revascularize more areas. So we did STMC double barrel bypass, which is clearly evident here, as well as coronal angiogram, and patient is doing well. In my 25 cases, there are complications also. In earlier part, I did try to do revascularization in a single setting. In 2 cases, I did bilateral revascularization with extensive pattern. In 1 case, we did 4 craniotomies, 2 parasagittal for indirect bypass and 2 frontotemporal for combined bypass. So vascularization was very good, but this patient suffered from scalp area infarct on both sides, and that area is almost lost at the later part. Had to transfer this patient to plastic surgery department, and due to poor nutritional status and other comorbidities and complications, ultimately we have lost this patient. Hyperperfusion is not uncommon. In 5 cases, 4 child and 1 adult. In immediate postoperative period, they become restless, irritable, excessive crying, poor feed, alteration of consciousness. But at the time of discharge, they become almost normal at 7 to 8 days. And at 1 month to 1.5 month follow-up, they all become normal, except the adult case. At 1 month follow-up, we have lost this patient at home. A postoperative infection is also a concern. It happened in 1 case. A patient presented with this scenario. We have done surgery 6 weeks later. We did right-sided, left-sided combined bypass. The bypass is well patterned, as well as CT angiogram also evident. But CT post-ops showing the infarct that was seen pre-op increased more than pre-op. And in contralateral side also, there is hypodensity. And CT scan, we did MRI. And MRI revealed excessive areas with patchy infarct in bilateral hemisphere. Patient was non-communicable at the time of discharge at 1 week, but she did very well. All symptoms improved. So results, I'd like to say out of 25, clinical improvement happens in 22 cases, with or without some sort of complications, minor complications, most of them. And complicated skin necrosis with 1 cases, we've lost this patient. Wound infection requiring exploration, 2 cases, doing well later. Hyperperfusion syndrome, 5 cases, 4 patients improved. And postoperative infection, 1 case, patient has improved. 2 death. So in conclusion, outcome of this limited case series is quite satisfactory, and complications are there, but decreases significantly at the later part of the series. I'd like to say strong motivation, perseverance, lab practice, and opportunities required to be a microvascular bypass surgeon. Thank you all for patient hearing.
Thank you, Dr. Arifin. That was very wonderful discussion and the presentation of nice cases. So I would like to open the panel for discussion. If any questions, yeah, we have one question from Dr. Biswas.
Yeah, thank you, Dr. Arifin. It was an interesting and very encouraging presentation. I have a couple of questions. When do we consider revascularization after ischemic stroke in Moyamoya disease, and also in case of primary ventricular hemorrhage due to Moyamoya disease? This is my number 1 questions. And number 2, do you consider catheter angiogram for Moyamoya disease? And what is the DSA no to revascularization in Moyamoya disease?
Thank you.
These
are
2 questions.
Thank you, Shanos. First questions, if patients presents directly after ischemic stroke, and it is diagnosed after diagnosed as a Moyamoya disease after angiogram, either CT angiogram or PSA, whatever. In acute setting, it is advised not to do surgery immediately, and rather to wait 4 to 6 weeks, and then after making the patient stable more. Because immediate revascularization, especially direct revascularization, may lead to hemorrhage in the infarct areas. So it has to be avoided. And second question is primary interventricular hemorrhage in adult case. We also deal with these patients in similar fashion. In adult, I got this ventricular hemorrhage patient in adult, not in children, and we did similar fashion in delayed fashion surgery. And regarding DSA, if the patient comes to us with MRI, MRA, CTA, and diagnosed as a case of Moyamoya disease, we never send these patients for DSA because it doesn't add any information at all. Rather, for after surgery, for assessment of patency of the bypass, either for academic interest, I have done some DSA in postoperative patients, especially in adult patients. And regarding endovascular management, I didn't have tried one, but literature says multiple stenting or angioplasty in Moyamoya patients in early stage was attempted, tried, but no significant improvement because history said it recurs and cause re-stenosis, and re-attempt may be done in earlier cases, but in later stages where there is no M1, no A1, maybe no role.
No, actually, I asked no endovascular management. I asked what are the angiographic no to revascularization. I don't want to do any revascularization after seeing the angiography, and especially catheter angiogram is important because at advanced stage of Moyamoya disease, there is development of the transosseous transdural supply.
Yes.
So in that case, if we go for revascularization, that may be detrimental for the patient. And that is why I asked, is there any protocol you follow to not to take decision for revascularization? Thank you.
Yes. In my 25 patients, actually in before first surgery, in no case DSA was done because we did in all cases perfusion weighted image. And in perfusion weighted image, if there is significant penumbra, though there is presence of transdural and transpile circulation, there is not enough. But for resurgery in contralateral side, those patients are doing well for 2.5 years, and I didn't do the contralateral surgery. those cases actually doing well, and their moya is not progressing. For those patients, if perfusion saying surgery is not required, for reconfirming it, I can go for DSA. Definitely, DSA has a role in that case to exclude the surgery. Thank you very much. Nice question.
Thank you. Excellent. Thank you all.
Thank you,
Can
Dr.
I say something before I go?
Professor.
I'm sorry,
Thank
taking
you for
your
staying.
No, of course. I watch and listen most of it. I miss some parts, but first, congratulations. Excellent. Doing moya cerebrovascular revascularization for moya with the limited resources you guys have is outstanding. Okay, so you should keep doing it. And also thanks to Professor Kato providing you guys this training and spreading the knowledge of microneurosurgery globally.
Yes.
And seeing these cases, I think is future of microneurosurgery. I'm sorry for US or European colleagues, but in Asia.
Yes.
Okay. And please keep trying. And you are doing great. And every single neurosurgeon in this podium should try revascularization for moya.
Thank you very much, sir.
Thank you. Thank you. I have to leave. And
Thank you, sir.
Alberto, thank you very much. Tamara, thank you very much. Thank you all. Professor Kato, hope to see you again in another opportunity. Bye-bye.
Thank you, Professor Ɓaskăja. Thank you so much.
Thank you, Professor. Thank you so much.
Thank you.
Now, Dr. Sukriti, you can ask your question, please.
Dr. Arifin, excellent presentation and very encouraging for all youngsters. I have a very simple question. In your first 5 cases, what is the most difficult part of the surgery you felt?
Yes.
For any upcoming budding neurosurgeon who's trying to do more of endovascular or more of microvascular, what would you advise?
Thank you very much, ma'am. I did practice STM, the microvascular anastomosis in my home. So bypass or anastomosis was not that difficult part. Rather, preparing the STA. In my first 5 cases, I have injured the STA in 2 cases. And I have anastomosed the STA to STA and then did the STMC bypass. So that was so irritating at the time of surgery because you are doing STMC bypass, you have cut the STA, and no one is appreciating. Everyone is red eye to you. So it was difficult, but I have overcome. I have calmed down myself, did STMC, and in those cases, post-op was great. So that I was lucky.
And one more question. Did you mark the STA before surgery with a Doppler, or only clinically you felt the STA and started the surgery?
Actually, I try to feel the parietal branch and trunk. I don't try to feel the frontal branch. It is always there. But parietal branch makes the difference. Parietal branch, if he can feel the parietal branch, I gives the incision mark over it till the superior temporal line, and harvest it along that line, keeping it continuity with the scalp.
Okay.
Not cutting it. Then keep the flap frontally, progress it, and from under surface of that flap, I harvest the STA frontal branch.
Okay.
And
Right.
Preoperatively didn't do use Doppler.
No need, that means. You're very confident that if we go slow and steady, we can harvest it.
Yes.
Okay. Thank you. Excellent.
Thank you, Dr. Arifin, for wonderful presentation and discussion. I now ask Professor FHU Bishnoi to continue with our next introduction of our Fujita current fellows.
So thank you, Dr. Arifin, for the wonderful talk, and it was very nice and encouraging for the young neurosurgeons and all neurosurgeons both. So now I would like to invite Dr. Farhad and Dr. Rakib, who are current fellows at Fujita, to introduce themselves. So I would like first Dr. Farhad to introduce himself. Dr. Farhad, kindly unmute yourself.
Yes.
Kindly introduce yourself. How's your
Yes.
experience?
Can you do you see my screen?
Yeah.
Thank you. This is my introduction to the fellowship program of Fujita Health University, Bantan Hospital, and I come from Bangladesh, and I am assistant professor of neurosurgery in National Institute of Neurosciences and Hospital in Dhaka, Bangladesh. So I come from Bangladesh to Japan last month. I arrived on 6th December, and I passed my medical graduation from Mymensingh Medical College Hospital in the year 2008, and did my government job for 2.5 years at rural area. Did my residency at Dhaka Medical College Hospital from 2015 to 19, and passed my master's in surgery in neurosurgery in 2020. And I did my thesis on comparison between endoscope-assisted evacuation and conventional bar hole aspiration of brain abscess. This was my thesis, and this is the picture with Professor Nazi Kocher of Turkey attending the first endovascular neurosurgery conference at Dhaka. And this is my mentors with my fellow colleagues. And in Link Asia edition in the year 2017, we attended the Link Asia edition conference with Professor Jacques Maury of France. And also at first ACNS BSNS hybrid conference, Dhaka, we attended the white fiber dissection with Professor Avida Shah, and also presented an article on the conference. And in this year, Professor Takeo Goto and team came to Bangladesh. I did assist him in the conference in the endoscopic skull base of doing a large giant pituitary macroadenoma. And this is my present working place, National Institute of Neurosciences and Hospital. And there are several departments in our surgery faculty: neurotrauma, clinical neurosurgery, neurospine, vascular, pediatric, gamma knife. And these are the surgeries we do nowadays: bypass, and this is one of the bypass of myomed disease, and microsurgical clipping. Also, we do endoscopic skull-based approaches, meningioma through transplant approach on pituitary macroadenoma, and also we do functional tumors of pituitary gland, Cushing's disease. And also we are now starting keyhole endoscopy concept to evacuate the intracerebral hemorrhage. These are the publications of mine on brain abscess, and another one on pituitary adenoma. So the Fujita days are going on very nicely and smoothly under the leadership and guidance of Professor Yoko Kato. I am learning CFD to construct CFD formula, CFD to study the hemodynamic parameters of aneurysms, doing bypass practices every day. And I get to observe the surgeries at Fujita and also at around some centers of Nagoya. And we got to know the exoscope and endoscope and microsurgical latest techniques. And also we get to assist and scrub up during the surgery. Thank you very much. And I am grateful to Professor Yoko Kato for giving me the opportunity to be a fellow at her institute. Thank you.
Thank you, Dr. Farhad. Thank you. So now I would like to invite Dr. Rakib to share his experiences.
Hello, can you hear me?
Yes, we can hear you.
Can you see my screen?
Yeah.
Yeah, I'm Dr. Mohammad Raqibul Haq, working in Bangladesh National Institute of Neurosciences Hospital. Now has come to Japan in Fujita Bantane Hospital for fellowship for 2 months. I was born in Bangladesh, Kustia district, a small district. Then this is my school. I went and my college. And then after college, I have graduated from Rajshahi Medical College and completed my graduation. And residency in neurosurgery, I have completed my post-graduation MSc neurosurgery from Dhaka Medical College in 2021. And then my thesis in residency was outcome of surgery versus conservative treatment in patients with spontaneous supratentorial lobar intracerebral hemorrhage. And I am working in National Institute of Neuroscience and Hospital as a neurosurgeon now and currently. And these are the departments already mentioned by my colleague Farhad. And my activities in the Institute of Neuroscience and Hospital. And some publications, case report, that is in case of COVID-19 patient, acute subdural empyema, lateral orbitotomic cavernous malformation. And my interest in muscular neurosurgery and also endoscopic keyhole and skull-based neurosurgery. We love Japan because a few months back, Professor Takio Goto attended in Bangladesh, Dhaka, cadaveric workshop and live surgery workshop. We are very happy to then, and Professor Eko Kato Sensei visited 2020 Dhaka in an annual conference of neurosurgery of Bangladesh. So from that point, we are very much encouraged to be a fellow in Japan. And we are very much grateful to our Professor Yoko Kato Sensei to give us the opportunity to come here as a fellow. And every day we are learning a lot. We are doing practicing microvascular anastomosis. We are seeing also endovascular procedures. We are learning about the cerebrovascular fluid dynamics. So we are enjoying the Fujita current fellowship. And this is my family. And thank you very much for patience hearing. Thank you all.
Thank you, Dr. Farhad. It's wonderful to see Fujita and you learning such a lot from Professor Yoko Kato and team. So I think now there are no more questions. So we can conclude the discussion. Professor Yoko, please give final remarks.
Okay, thank you very much. So Tamara, thank you very much for your the good guide of the anatomy of the brainstem. So it is very, very important because Mustafa, he emphasized because anatomy, only anatomy is the most important, he mentioned. And also, of course, the Mustafa's lecture was outstanding, so we learned a lot from him. And also, Arvind, thank you very much. I remind you that your inspiration and your enthusiasm to learn the microvascular surgery. But I think Moya disease is one of the most difficult anastomosis technique, I think. Maybe you can learn them. Sometimes scotic change the elder people that you can have a chance to anastomosis. Because maybe some limitation of the many things at your place. So maybe I think you have an ICG, of course. Okay. Yes. Yes. Okay. Sometimes.
Arifin, unmute, please.
Okay, please. Okay. Thanks. So maybe I think maybe we can send a good anastomosis video for your place. I think maybe Papa he can send some video for you. I think. Anyway, the three talks was so outstanding, very nice. So and also the last the two presentation the current fellow of others, they work so hard the day and night, and they can have a chance to visit another institute maybe in the next month. I say going to Tokyo, meet 𝑎𝑙𝒊𝒏𝒔𝒕𝒊𝒏 and also the Tamara. So we had a very good time, too much to study. Thank you very much, all of you. Thank you.
Thank you.
Thank you, Professor. Thank you. I think we can close our webinar today. Thank you, Professor Kato. Thank you to all the three speakers. Thank you to Ishu and Hari for this co-moderation. And I will see you all next month, February 4th, for the next FHU Alumni Association webinar. Have a good day.
Thank you very much for the nice session.
Thank you.
Bye.
ありがとうございました。
はい、おやすみなさい。Very good. Very good. ありがとう。おやすみ。はい。
ありがとう。
アリ先生、またね。バイバイ。
バイバイ。バイ。
おやすみ。